Welcome to this video discussing grief and bereavement in children's palliative care. This video is part of the REACH series of core videos. The objectives for this video are, by the end of this video, you will be able to explain key concepts related to grief and bereavement, describe how children grieve at different developmental stages, recognize and respond to grief in caregivers, including anticipatory and complicated grief, and implement practical strategies to support children and families as well as healthcare teams experiencing loss and associated grief. Let's start by looking at a case. You are caring for Aisha. She is a 6-year-old young girl with relapsed leukemia, whose disease is very advanced and refractory to chemotherapy. Aisha has 3 siblings, Lila, who's 4, Alex, 8, and Noah, 12. During a clinic visit, when you're outside of the clinic area, Noah finds you and asks privately, "Is my sister going to die?" You don't answer him in that moment because you're stunned and not sure how to proceed. Later, the parents tell you that they actually prefer not to discuss death with the children because they want to protect them. Let's explore how parents' desires to protect children and children's need for information sometimes clash, and how we can support and navigate these challenges. Let's get started with a few key terms. Grief is the total active experience of loss. Mourning is the outward expression of the loss, and it's a style of how we express loss. It's determined by culture, religion, spirituality, and beliefs. And bereavement is the state of having lost someone or something dear to you. If we think about why we grieve, it's because we attach and we love because we are human. When we lose something or someone we're attached to, that's when we grieve. So it's kind of like we have the relationship and the love in that. That is a form of attachment. And when we have the loss, that's where the grief comes in. Grief usually is feelings of sorrow, numbness, guilt, and anger. Gradually, these feelings do lessen over time, and it is possible to accept the loss and move forward. But it's important to think of grief not as something that needs to be fixed. We will grieve for as long as we love, so grief really has no timeline. We're all different and we have different experiences of grief. And what we know is that what is helpful for one person is not always helpful for somebody else in their grief. This image shows how usually the grief stays the same size and the person's life gets bigger around the grief, instead of thinking of the grief as becoming smaller as part of the person's life. If we think about some key theories about grief, in the past, grief was described linearly, like a progress along a line through a series of phases or stages until the person was better. But now we know that instead we can think about grief through a series of patterns or tasks that people go through as they process grief. One example is Worden's tasks of mourning. The tasks include accept the reality of the loss, work through the grief, adjust to the environment without the deceased, and develop continuing bonds, meaning you develop a new relationship with the loved one. Anticipatory grief is the rehearsal and preparation for a loss. This preparation can be helpful, knowing that the person will die and starting to prepare yourself, but it does not prevent the full experience of grief that occurs when the loss happens. Anticipatory grief can be experienced by the person who's dying as well as by their loved ones. Prolonged grief is defined as feelings of grief that are both debilitating, meaning really taking a huge impact on the person's life and their ability to function, and do not improve 6 to 12 months after the loss. The timeline is a little bit controversial because we know that for parents, grief may actually be worse in the 2nd year after the loss of a child. Other symptoms of prolonged grief include being unable to focus on little other than the person's death, thoughts of guilt or self-blame, feeling as if life isn't worth living, wishing to have died along with the loved one, inability to do their regular tasks of living, personal hygiene, childcare, attending work or school, and household chores, and anger, irritability, and hostility towards others. There are a number of risk factors for prolonged grief, including sudden death, death in intensive care units, poor symptom control at the end of life, unresolved conflicts, or decisional regret about the choices that were made which were preceding the person's death, and previous trauma, mental illness, other losses, and grief. And we know that prolonged grief often requires psychotherapy from specialized psychosocial care professionals. The question often comes up of, is this prolonged grief or depression? We know that grief is difficult and sad, and a depressed mood can be part of grief, but it can be also distinct, that grief is not equal to clinical depression. A person can be grieving and clinically depressed. And interestingly, recent studies show that yearning, meaning wishing to be with the person who's died, is the most prevalent negative emotion in grief rather than sadness. The death of a child is unique. There's the loss of their future, their hopes, and the identity that the parents and others had for that child. There's the wider impact of a child's death on parents, siblings, extended family, and the child's community, including school and their religious community if they had one, and the clinicians who cared for the child. We know that grief is protracted or prolonged for many parents, and they often tell us that the second year is worse than the first after the child's death. Milestones such as holidays, birthdays, anniversaries can create a strong resurgence in someone's grief. And if we look at grief in parents, we know that there's some unique features, particularly their loss of identity as a parent for that child. They can have survivor guilt, wishing that they could have taken their child's place and been the one who died. And if they had to make decisions about medical treatments and care, they can question these and worry that they did something that caused their child to die or to speed up the death. There's many differences in different cultures between how grief is expressed by mothers and fathers, and these cultural expectations of how much mothers or fathers or parents are expected to be strong versus show vulnerability and weakness and sadness in grief. Grief impacts the parents' relationship with their spouse and how they parent their surviving children. And as we mentioned, grief timelines can be much longer. As we think about the grief in the whole family, meaning the child and the parents and other people who live in the home, we know that each family member will grieve in a slightly different way. For parents, their energy is distracted by the emotional energy of grieving their child, and then this exhausts the emotional energy of the family. And there's a competition between different family members. For example, siblings feel that they must compete and perhaps get the parents' attention, or they feel ignored because first the parents were focused on the ill sibling, and now the parents are focused on grieving the loss of the ill sibling. And siblings often feel quite conflicted about this. They don't want to resent the sibling who's died. They feel sad, but at the same time, they may feel happy because now there's more attention potentially on them in the future they hope for. This can become what we call a pressure cooker, where each person in the family has a high need to be understood by other family members, but a low capacity to understand others. If we think beyond the nuclear family and think about the wider community, classmates of the child will have questions and fears about their own health and mortality after hearing that the child has died, and their reactions may be similar to bereaved siblings. Attendance at funerals, having class memorials or school assemblies to acknowledge the death of the child can be supportive. Again, this is all modeling grief and bereavement behavior so that children understand how they can express it, and this is helpful for them. Teachers and staff will also have feelings of grief and may need opportunities to process these feelings so that they can support the students in their class. And we've seen successful examples through oncology programs who offer school visits from a nurse or a counselor to support students and staff and explain what has happened. Let's go back to the case of Aisha and her siblings. We should think about each of these children's capacity to cope with the impending death of their sibling and how this will be affected. It'll be affected by their relationship with the child who's died, about the nature of the death. Was it a sudden death? Did she go to the hospital one day and not come back, and they were not prepared or expecting this, versus a slow decline where they see her health deteriorating? Their age, both chronologically and developmentally, and particularly the support they receive from others, especially their parents. We often think of siblings as what we call hidden grievers. They are invisible to parents in their grief. Parents say, "Oh, he's okay, he's doing okay, he's so strong." But that's because the siblings perceive this as something the parents want from them, a way they feel the parents want them to behave. And there can be cycles of grief. Each time a child ages and changes in their developmental understanding of the grief, they may re-grieve the loss of their sibling. Let's look at how grief affects children in different age groups. If we look at Layla, who's the youngest, 4 years old, her understanding of death will be like those of a preschool child. Death is temporary and reversible. They have magical thinking, meaning they may imagine that they did something to cause the death. Emotional responses are confusion, clinginess, meaning not wanting to leave the parents, regression, including bedwetting or baby talk, irritability, and tantrums. These children need repeated, simple, concrete explanations of what is happening. For example, your sister is very sick with cancer and the doctors are helping her to not have pain. And it needs to be simple and clear so we avoid any euphemisms for death, meaning any unclear ways of saying it, such as she went to sleep, she's gone away, she's gone to heaven. Strategies include maintaining routines, providing reassurance, using play or art to express feelings, and ensuring consistent caregivers. And I want to emphasize how play can be very helpful for children to express and explore feelings, and we can have guidance for parents about how to communicate and what strategies to use. And there's a number of helpful resources that I'll share later in this video. If we think about Alex, he's at school age. And at this age, children begin to understand that death is permanent. It's a change from being alive to a different kind of existence. If the family has a belief in the afterlife, then the child will explain it in that way as well. For example, believing that the sister has gone to heaven after she dies. Typical emotions include fear and anxiety, regression, and more somatic symptoms such as stomach aches, pain, tiredness. Children at this age need to help to understand what is happening. Specifically, they need to understand that they did not cause the death, and they need to help finding words and appropriate outlets for feelings. Key strategies include predictable, familiar routines and encouraging them and letting them know it's okay to ask questions and express their feelings. They respond well to opportunities to express grief without judgment through play, art, and words, and through seeing their parents and other loved ones express grief so that they know it's okay to do that. For adolescents such as Noah, their understanding of death becomes that it is final and irreversible. Emotions are more mature and include those we commonly see in adults, such as sadness, anger, guilt, and anxiety. Again, they may feel neglected or invisible. We talked about that idea of the hidden griever. And they can experience anticipatory grief, meaning that they will be grieving before the child dies. And that's what you saw with Noah in this example, where he asks, is my sister going to die? He wants to know because he wants to start to prepare. At this age, adolescents need clear information. They need opportunities to ask questions, and they need our help in validating their emotions, their questions, and their uncertainties. Many times they value privacy, so they may want to talk privately with the healthcare team, but it's also important to offer them the option of being involved in family discussions with parents and the healthcare team, and helping them maintain their school and friend connections. Supports and resources that are particularly important may include counseling, sibling support groups, and supports through school. Puddle jumping is an idea which is often spoken about in children's grief. This is the idea that grieving children may alternate between great distress and a seeming lack of concern, a bit like they're jumping in and out of a puddle. Young children can grieve, we know that, and we know that they want to be understood, and they want to understand what has happened. So we need to explore if and how they want to be included. It's okay to ask a child, do you want to hear? Do you want to be part of this discussion? And then, of course, the discussion can be adapted to their age. And then there can be a time when they step out of the room and the discussion goes to a higher level, more mature with the parents. Sometimes in the past, people said, oh, children just bounce back very quickly from a loss. But this is not necessarily true, and it depends a lot on the support we give them. And again, children may appear that they have bounced back because they puddle jump in and out of their grief, or because they're trying to hide their grief because they don't want to further upset their parents. Another key concept is the idea of a grief garden for children. What this means is that we create an environment around the child that supports their healing process. In this environment, children feel able to share with trusted and caring adults about what they need, about what their questions are, about how they're feeling. We recognize that the grief is a healing process. It's not an illness or something that needs to be fixed. And we encourage expressions of feelings, concerns, and questions. Again, we recognize the importance of play. It's this familiar activity. It gives a safe outlet for children. It's a way for children to express feelings in the way that adults and older people express feelings through words. Children express through play. In play, the child has the chance to make choices and control the outcome. So they can adapt the situation. They can play themselves being sad, but then they can say, oh, now I feel okay because I know my brother or sister isn't having pain and he's in heaven, whatever their understanding would be. Play can also help children understand their life experiences, things that they may not have thought were normal to them. They can normalize by reenacting it and exploring it. That's why many times hospital playrooms have play hospitals, have toys, toy doctors, toy nurses, all the elements that you see in a hospital to allow children to manipulate this, play with it, and understand it. It's important to help children ask questions. I want to show you some questions that children spontaneously asked when we provided a question box where they could write questions on slips of paper and submit them. These were siblings of children who had a serious illness, and they were attending group sessions once a month that were just exploring the fact that they were a sibling of an ill child. But we offered them the option to submit questions and share what they were thinking, and these were anonymous questions they were able to submit. So this child has asked, why is my sibling eating less? My mom cries a lot and I wonder why. How is the syndrome made? Again, really emphasizing the importance of explaining to children what the child's illness is, what is the syndrome, what is the name of it, using the words so that they're not afraid of those words. When will they pass away? So again, it really emphasizes that children are very in tune with what's happening to their sibling, and they want answers to those questions. So we know that in general, there are 6 C's that help us remember what's the information that we should be sharing with children or that they might be worried about. What is it called is the first one. So giving the illness a name, naming the condition. That way it's less scary. What caused it? Particularly, they worry that they caused it, and we should always address the fact that they did not cause it. Can I catch it, right? Children are exposed to many infectious diseases. At school, they see, colds, coughs, flus, things that you can catch. So when a child has an illness, they may not understand that this illness, for example, cancer or syndrome, is not something you can catch. Can I cure it? Who will take care of me? Again, children are very egocentric. They're worried about themselves. If my sibling's sick, who's going to look out for me? Who's caring for me? What about my parents? Will they give me the attention I need? And how can I connect to those who love me? Some key grief resources are available here, including Sesame Street, which has a whole module on grief and bereavement and videos and resources for young children, and you can access all of that by scanning this QR code. I also highly recommend kidsgrief.ca and teengrief.ca, which are websites available both in French and English that provide resources for parents, teachers, and others who are helping children with grief. And Teen Grief, which actually is designed by teens, for teens, and helps them explore their own grief. Storybooks can be another excellent resource, and here are 2 books that are often used to talk to children and help them explore their feelings around grief and loss. The Invisible String and When Dinosaurs Die. Let's go back to the case of Aisha and imagine a little bit of a different scenario for her. She's 6 years old with advanced relapse leukemia. In this scenario, 3 months before she was diagnosed, Aisha and her family were forced to leave the city where they had lived. They had to flee to a smaller town where they were living in a tent, and this was because of ongoing war and violence in their home country. So when Aisha was diagnosed with leukemia, treatment was not possible in this small village and in her home country because of the violence. So Aisha and her mother were evacuated to a nearby country, leaving behind her father and siblings. So imagine this family in the midst of a very traumatic experience in a humanitarian crisis. They've been forced from their home, and now they're separated because Aisha needs treatment and it's only available somewhere else. So now her life is confined to a hospital bed, far away from everything she knows. She doesn't have her culture, her language. She only has her mother. She's always been with her siblings, cousins, and friends, and now she's so isolated. So this will have a huge impact. We know that in humanitarian settings, the displacement, the conflict, these have a huge impact on the experiences of grief and bereavement for families. There's often a lack of formal bereavement services. And in addition to this, there's usually higher child mortality and a normalization of loss. And many times there's more limited access to curative treatments because the health system has been disrupted. So all this is making it more challenging for us to support grief and loss. It's important to also remember the cultural, spiritual, and religious dimensions of any loss. Think about in your culture. What are the cultural variations around beliefs about suffering? Many cultures believe that you must go through suffering, that there are rewards for going through suffering in this life that you may have in the afterlife or in the next life. What are your cultural variations in your culture around death, around beliefs about the afterlife? What are the important rituals, the mourning practices, and the taboos at the time of death? These will vary. Imagine Aisha and her family displaced to a new country for her treatment. If she dies there, how will all these things be navigated? How will the healthcare team know the cultural variations in each of these for her mother? So let's conclude this video by looking at 4 key actions that healthcare providers can take. They are empathetic communication, memory making and legacy, support after death, and self-care. First, let's look at empathy. Empathy is the idea that you are a genuinely curious and good listener. You validate the emotions that the person is sharing with you, and you imagine yourself in their situation. You try to just be present, be authentic, be supportive, and be yourself. You share and feel with them. So here is a helpful acronym, NURSE, which can help us to be prompted for how to show empathy. So N stands for name. You can name the emotion you're seeing if they've expressed it, or if you're not sure what the exact emotion is and you don't want to be precise because you worry that they may disagree with you, then you can say, I see you're experiencing a lot of emotion, a lot of feelings right now. That allows you to acknowledge it and put it out in the open. U stands for understanding. This is a lot to be dealing with. This seems to be very difficult for you right now. You're just showing that you can see that this is hard for them. R stands for respect. You can say, you're good and loving parents. You have done everything you could for her. I can see how much you care for her. S stands for support. I am available when you have questions. I and my team, we will be with you. We will keep looking after you and your child. This is important because families may feel that if they are no longer taking treatment, for example, cancer treatment, then who's going to care for them and their child? And we need to always emphasize, we will keep caring for you. We will keep supporting her, whatever she needs, in whatever phase of illness the child is in. And lastly, explore. This gives a way for you to ask them to tell you more. Tell me more what you're thinking. Tell me more what you're feeling. Help me understand what your thoughts are right now. So these can all be really helpful questions to show empathy. Other key components of empathetic communication include sharing clear information. Tell families what has happened and what to expect. Each time there's a change in prognosis, this is a time. What has happened to this point? Make sure they understand. What are you expecting to be next? Families do remember very clearly the words that you use at the time of the child's death and how their child's death was communicated to them. So it's very important to be prepared and have the right words ready. Things that we should avoid saying. I know how you feel. Families say that nobody knows how they feel. This is a unique experience. Avoid saying, don't worry. Don't worry, instead of making people not worry, actually makes them feel like their concern and their worry is being dismissed. Other things to avoid. At least they aren't suffering anymore or they're in a better place. This is not helpful. You are lucky to have other children or you can have other children. So please avoid saying all of these phrases. The second key action that health workers can take is memory making and legacy building. This supports meaning making, and ongoing bonds with the child. So this can start before the child dies and continue at the time of death. Examples of things that families may accept and feel are appropriate for memory making include making handprints, footprints after the child dies, taking a small lock of hair and keeping that somewhere special, taking photos, creating hand molds, as you can see in the image here, writing letters, taking video recordings, creating storybooks together, and celebrating rituals and anniversaries, both before the child dies with special meaning if you know the child is going to die, and remembering these after the child has died as well. Again, these will be influenced by the culture, the religion, and the beliefs of the family. But you can offer these things. Do not assume just because someone is part of a certain culture that they will accept or reject some of these offers. So it's important to offer them, allow them to select what they feel is appropriate based on the resources you have and what you've decided as a team you will be able to provide. I think the smallest and most simple things, such as just offering to take a photo, offering to take a recording of the child's voice, or encouraging the family to do that, or taking a hand and footprint, can be done with very little additional resources. If we think about the third action that health workers can take, it's ensuring there are some supports after death. Again, this is often what is lacking. It's what we haven't learned how to do. It's not necessarily what hospitals and health facilities think about and are set up to do. But it's important when we're providing palliative care to think about what will we do after a child has died? How will we support that family? This might be a condolence call. At a particular time after a family's child has died, you may say, I'm going to call after a certain number of days, whatever is the appropriate mourning period in your culture. You could also write a letter just saying, I remember your child, thank you for allowing me to care for them, and send that. If they don't have an address, you could write it and then take a photo and send the photo. And you could also do a bereavement visit. Many home-based care programs provide a bereavement visit from a nurse and a social worker after the child has died. As programs become more organized, you may offer individual or group counseling or support groups. And you may offer the opportunity to participate in rituals. For example, many palliative care programs will have a memorial service once or twice a year where they bring together a number of families who have lost a child in the past months or years. Again, these are determined by the culture and the religious and the other aspects of the situation and would be something that you would consider based on what's appropriate in your setting. The fourth key action is to remember to care for ourselves. As healthcare workers, we will experience grief. We experience that when we lose a child, when a child dies who we have cared for. And this happens over and over for us, right? We continue to care for other ill children, and so we have cumulative grief. We may have moral distress. This can be especially linked to when we can't provide care in the way we would want to, perhaps because the resources aren't there, or when we're providing care that we don't feel is in the child's best interest. For example, providing excessively high-intensity care when a child is actively dying can cause us great distress because we know it's not prolonging the child's life, and instead it's causing them pain and suffering. This leads us to become burnt out. We may have disenfranchised grief, meaning we don't feel that we should be feeling grief because we're not related to the child or we're not part of their community, but really we should acknowledge that they are important to us and we can feel that grief. Other key self-care strategies include debriefing. We highly encourage palliative care teams or those providing serious illness care to children to debrief after a child dies. This also offers an opportunity for reflective practice to say, what did we do well in this situation and how can we improve in the future? Peer support, both one-on-one and group support at our health facilities, can also support us in these situations. And having rituals in the workplace after a child's death. For example, many hospices or palliative care programs will put out a small ornament or light a certain lamp, light a candle, just to indicate a child has died or a child is near the end of life. And then it's important for us to balance our work with activities outside of work. Have other hobbies, exercise, other things that bring us joy and connect us to those around us. So in summary, the key take-home messages from this video are: grief begins at diagnosis, not just with death. And we talked about the idea of anticipatory grief. Grief is not just a problem to be fixed. Instead, we should think of it as a unique experience for each person. We learn that children grieve differently, and differently at different ages and stages of development, but not less. And grief is shaped by culture and rituals. We lastly talked about the 4 key actions which I hope that you'll be able to put into practice after today. First one being empathetic communication and the NURSE acronym. Secondly, memory making and legacy building, creating those connections and a way for families to have an ongoing bond with their child even after their child has died. We talked about supports after death, including potentially phone calls, condolence letters, or organized support groups facilitated by members of a palliative care team. And we talked about self-care, which includes both personal and institutional strategies to allow us to continue to care even when there is cumulative grief involved, and to make sure that we do acknowledge the grief that we feel and not let it be disenfranchised. Lastly, I'd like to highlight some key resources which are freely available. This handbook can be downloaded for free if you scan the QR code, the Global Handbook of Children's Palliative Care, and includes sections on grief and bereavement, as well as management of other symptoms in children needing palliative care. And some other free online resources include the International Children's Palliative Care Network e-learning program, which includes a module on grief and bereavement, and the websites of kidsgrief.ca and teengrief.ca, which I mentioned, which provide online resources for parents, teachers, children, and teens, and the Sesame Street workshop, When Families Grieve, which is well suited to the needs of young children with simple videos and activities to guide parents. So thank you for watching this video, and I hope this helps you as you learn more about children's palliative care and grief and bereavement.